right, I think we'll go ahead and get started. We will have continuing individuals joining us today, but certainly want to respect your time and get started. I am going to introduce Dr. Jamin Blood, and then I'm going to ask that Dr. Mary Baker introduce herself. So one moment. Dr. Blood is a native of rural East Texas and started his college education here in Tyler at TJC, and then also attended University of Texas at Tyler. He also attended school at Louisiana State University in Shreveport, attended medical school in Kansas City, and then also where he completed his doctor of osteopathic medicine. Dr. Blood also continued his education, specializing in child and adolescent psychiatry, completing his fellowship at UT Southwestern in Dallas. Dr. Blood is certified by the American Board of Psychiatry and Neurology in Psychiatry and joined us in fall of 2020 as an assistant professor of medicine in our Department of Psychiatry and Behavioral Medicine here at UT Health Science Center. His specialty interests include treating children, adolescents, and young adults with a variety of psychiatric illnesses, and also treating very young children and those with special needs. Dr. Baker, will you go ahead and share about yourself, please?
Sure, thank you, Laura. So I'm Dr. Baker. I am currently a psychology fellow here at UT in the TASK program. So I am working on specializing in children and adolescent psychology as well as trauma. Got my undergrad in psychology at Baylor and recently completed my PsyD at Regent University, which is a very small school all the way in Virginia. So I'm happy to be here. Okay, so we'll go ahead and get started. Today we're going to be talking about behavioral management of ADHD. Just to review our objectives, at the end of the presentation, you should be able to summarize interventions specifically for executive functioning, describe parent training techniques for attentiveness, recognize interventions for emotional regulation for children with ADHD, and then we'll conclude by incorporating some behavioral management techniques into practice. So to start off with, I'm sure we all know what executive functioning is, but just to review, it's a set of skills that include working memory, planning and organizing, flexible thinking, and self-control, among other things. So children who have ADHD have deficits in executive functioning, and this can lead to difficulties in lots of different areas and domains, but today we're going to cover specifically difficulties at school, in social life, in regulating emotions, and at home. So to start off with, we're going to cover specifically strategies and tips for school interventions. So as physicians and providers, we really want to stress the importance to parents about sharing their child's diagnosis and any evaluations with the school. So usually when parents are first receiving that their child has a mental health condition or ADHD, that can be very overwhelming for them. And usually all the information they're receiving is just kind of going over their heads. They're not taking much in. So we want to keep in mind that schools typically or should have all these things in place for their child to help them. They've dealt with other children with these needs. So being able to share a diagnosis or an evaluation with the school, they can make an individualized education plan, a 504 plan, behavioral plan, whatever it is that they do. So just making sure parents share this so the school can help them in the best way possible. So a few things that the school can do is first, just providing additional time to complete assignments, also some comprehension checks. So throughout the day or throughout going over different tasks or lessons, the teacher can stop, take a moment to make sure that the child is still on track and hasn't lost attention too long and not having the ability to come back. Also, breaking down multiple step directions. So children with any mental health concerns, but especially ADHD, they really struggle to remember multiple steps. They're already dealing with hyperactivity and attention difficulties. So often once they complete the first step, it's hard for them to get back on track. So we want to make sure that the kids are having a chance to succeed in breaking things down that are achievable and attainable for them. Also allowing for breaks, especially from tasks that are very heavy attention or require like sitting still for a long time. So this could look like things just taking a stretching break, walking to the water fountain back, coloring break, something small like that. And then modifying the schedule so that attention heavy tasks are maybe at the beginning of the day or during the day when we know the kid has the most attention. And this is also important for parents too. So all these things that happen at school, we know parents are the ones at home enforcing homework and other tasks. So for parents, the first few minutes when a child comes home from school, they probably don't really want to talk about something really intense or want to start on homework really right away. So just modifying the schedule so that way the kids' focus is at the highest whenever doing a task. Some other things would be adjusting the classroom setting to minimize distractions, providing organizational skills. So this could be like planners, folders, anything that helps them keep track of what they're working on. As well, we want to keep in mind that children with ADHD do really well with caregivers and teachers who are calm, firm, positive, encouraging. Another thing that could be really helpful is setting subtle cues in the environment. So whether that is like signs of where things go or laying out different bullet points of what comes next after, you complete your math, you need to grab a book or move on to this next activity so that way they have these cues in their environment. So other things, like I said, limit multitasking and limit distractions. So at home, if a child's doing their homework, usually parents put them in the kitchen or the kitchen table with the TVs on. That's not going to be the best place of success for them to get their stuff done. So now I'm going to talk a little bit about interventions in social settings. So for individuals with ADHD, a lot of research has shown that they struggle, excuse me, in their social environment and in their relationships with peers. So there is an evidence-based treatment specifically for individuals or neurodiverse individuals such as autism and ADHD that helps teach them the skills and give them a chance to practice them with other peers. So this is the program for the education and enrichment of relational skills or peers. And they specify it for different age groups. So they have for younger kids, for adolescents, and for young adults. And it's typically a 14-week group where the child's in one group with a group of clinicians where they're learning the skills, practicing with their peers and getting feedback. And at the same time, their caregivers are in another group with clinicians who are covering the same skills, how to go over the skill throughout the week, how to help practice it at home and in their other environments. And so some of the things that they talk about are how to have a good use of conversational skills, how to use electronics appropriately, using humor appropriately, and being a good sport. And as we know, a lot of kids with ADHD and autism do have some teasing and bullying at school. So this also focuses on helping them handle those things at school with their peers. So next, just a few things about emotion regulation. So as we know, or as research shows, kids who have ADHD can also really struggle with regulating their emotions. And so we want to make sure we're giving them and their parents some tips to help with this aspect. So emotion regulation is the ability to exert control over or modulate their own emotional state. So to be able to successfully regulate our emotions, children have to be able to consciously monitor themselves, how they're feeling, what they're thinking, how their body's responding. So they learn different cognitive and behavioral techniques that teach them the relationship between emotions, behaviors, and their thoughts. And so if they're dealing with one particular emotion or a couple and really struggling to regulate them, they learn how the relationship between their thoughts and emotions works and ways to help them with those emotions. So some evidence-based treatments that are really help with emotion regulation is cognitive behavioral therapy, or CBT. This will focus on physiological or relaxation coping strategies, teaches, again, that connection between their thoughts, emotions, and behaviors, and the strategies to deal with them. Trauma-focused cognitive behavioral therapy, or TFCBT, goes over the same strategies, but it has the added component of processing trauma. So if a child has ADHD and trauma, we really want to make sure that we're allowing them to process those emotions and what happened, because research shows that trauma can look like a multitude of things, and ADHD is one of them, that it can look like ADHD, but maybe there's trauma going on as well. And then also just different parent training techniques, which we will go into in just a moment. So some quick, easy interventions to teach for emotion regulation. One would be just deep breathing, helping the child just take a moment, calm their bodies, and regulate the breathing. Also identifying their emotion. So many kids struggle to know what are they actually feeling. So maybe they are acting really impulsive, very hyperactive, seems out of control, and maybe they're just really stressed and they don't have the words to say, I'm really stressed, all these things at school and at home are overwhelming for me. So it can come out looking like, another behavioral difficulties. So teaching kids like names for emotions, but also how their body responds to the emotion is helpful. We also want to encourage children to learn to regulate those emotions when they're really high and they're struggling with them, and not repressing them, because as we know, emotions will find a way to come out. Self-soothing techniques is another quick intervention for emotion regulation. So this can look like, for ADHD, kids who are really struggling with hyperactivity, some kind of fidget, something to kind of focus that hyperactivity, whether it's like a fidget or slime or something that they can have their hands on. Soothing techniques can just be getting the child to engage all of their emotions, or senses and emotions, to help ground them in the moment. So focusing on what they can see, hear, smell, feel, and that brings them back into the present awareness instead of maybe where their mind is racing all over. And then also encouraging a child to talk with someone they trust. So just letting them know that who are those people, helping them identify them in their lives that they can talk to. So next, some of the evidence-based treatments for parents and caregivers to use with their child. We'll go into them more in detail, but parent-child interaction therapy, or PCIT, and then Barkley's Defiant Child Manual, and then just general parent training. So when working with parents who have children who are really struggling, maybe very hyperactive or impulsive, we want to help them be able to identify the function of the behavior, or the ABCs, and giving them that more of that knowledge so they know the best way to intervene. So the A is the antecedent, what happens immediately before the behavior. B would be like the clear, specific behavior that's happening, and then consequence, what happens immediately after the behavior. So an example could be, the child was at school from 8 to 3, comes home, the behavior is they start running wild, jumping up and down all over the furniture, throwing things, and the consequence, the parent is overwhelmed and says, hey, get on your video games. So using the ABCs, we really want to be able to identify what is propelling this behavior, what is helping it to continue to happen, what is the child probably getting out of it. So looking at the antecedent, keeping in mind genetics or family history, the client's own experience or history is very important. But also, what are the immediate triggers? Who's present when this behavior occurs? What are maybe events, thoughts, or feelings that the child may be experiencing before the behavior? Where does it occur? When does it occur? And just keeping in mind what all could be happening. So in the example I just gave, maybe the parent is like, the child only does this for me. They don't do it with the babysitter. They don't do it with the grandparents. They just very hyperactive when they come home with me. So the parent is maybe one of the triggers, maybe right after school is a trigger, and the consequence, looking at what happens after the behavior occurs. So the child is acting up, being very hyperactive, they get to go play their video games, or how is the parent responding? So if the child knows, like, I come home, I'm tired, and I drive my parents nuts, I get to do what I really want to do, playing video games. Or maybe the grandparents or the babysitter never gives in. So just keeping in mind, what are the things that are helping the behavior continue. So for parents, part of the PCIT treatment that I mentioned, one of the things it really focuses on is attending to positive behavior. So we want to help parents, with this skill when they're dealing with difficulties, especially with compliance, or just being able to behave in a way that they find appropriate. So in PCIT, it kind of goes over really paying attention to when the child is complying, or when they are doing things right away, or what we call maybe good behavior. So we really want to catch the child in the good. Also teaching parents that when they are catching the child in the good, or seeing that the child is listening right away, using a specific labeled praise. So an example would be telling the child, like, hey, you need to go put your dishes in the sink. They do it, you say thank you. That's very nice. The child knows that they did something right, but if we want to see that behavior increase again, we really need to use a specific labeled praise, like thank you for listening right away, or thank you for following directions the first time. So as we know, children really seek attention, whether it is positive or negative, and so helping them see that these are behaviors you can do to get a lot of positive attention from the caregiver. And here in a minute, we're going to go over commands. So you want to make sure if you're giving a command or asking a child to do something, using the positive attention with that, and make sure to pay attention, what is something the child is struggling to follow through with. If they're struggling to follow through with something consistently, then maybe we need to, reapproach how we're asking the child to complete it. So in PCIT, it also goes over giving effective commands. So commands would just be the way you're asking your child to do something, or asking them to comply with a certain task. So when giving a command, we want to make sure you mean it. Like if you're asking the child for something, you really want to make sure that this is something you really want. Not presenting the command as a question. So if we ask the child, will you please sit down and do your homework, that gives the child an option to say no. Like they can answer yes or no, and then that can start a whole nother battle. So just really giving it in a direct way that doesn't really, leave room for interpretation. So like, please go sit and do your homework, or go to the table and do your homework. Again, we don't want to give too many commands or ask the child to do too many things at once, just because after the first one, they might have already forgotten all the other things that were asked of. Telling your child what to do rather than not what to do. So an example, we might say, quit running, quit hitting your sister, and then the kid starts jumping and doing cartwheels on the furniture and is poking the sister. Well, technically they did, follow the direction of not running, not hitting the sister, but, parents will probably still be annoyed and still ask the child to stop doing something, and that can create more distress or more turmoil between the parent and child. So instead of quit running, a parent might say, sit on the couch. Or instead of stop hitting your sister, please keep your hands to yourself. Avoid competing distractions when giving commands. So if the child's playing video games or is on their phone, they might not really be listening to what the parent is saying. And then also being cautious of commands that may involve the concept of time. So if the parent is in the car on the way home from school and is saying, in a couple hours you need to get dressed for soccer practice, the kid's probably going to forget or wasn't even paying attention. So we really want to make sure that the child is set up for the most success and limits the confrontation or arguments between the parent and child. So next, just some tips for effective discipline that the evidence-based treatments go into. One is active ignoring. So I've seen videos and heard parents talk about their child comes in, says, "Mom, can I have a cookie before dinner?" Mom says no, and the kid flings himself on the ground and is crying and screaming like crazy. So the mom goes maybe into the living room to fold laundry. The kid comes in there, gets up very calmly, walks into the living room, throws himself on the floor, screaming and crying. Again, they want that attention from the parent. And so active ignoring just kind of includes the concept of ignoring behaviors that the parent doesn't want to see, as long as the child and everybody's safe in the home. So if the child is having a tantrum, just, you can still see them out of the corner of your eye, but you're actively ignoring that behavior. And as soon as the child stops, maybe they sit up and they start looking at something, giving really big praise, I really like it whenever you are able to calm yourself, or I really like how quietly you're sitting there, and then pouring out the intention to things that you do want to see more of. Timeout is another effective discipline. Again, the goal is to decrease undesired behaviors by removing parent attention. So this would be if the child is hitting their sister and they haven't stopped putting them in a space where there's no other distractions or no other external reward. So a lot of the times parents will send their child to their room and the child has, toys and other video games in there. So it's not really, punishment for them. They feel like they're just going to go play somewhere else. So maybe a corner or a chair where they can just sit, they can't see the TV, and as soon as a couple minutes have passed by, giving them back all the parental attention. Again, this is probably most helpful for younger children. I don't see a lot of success in putting a 15-year-old in timeout, but some other discipline is point systems and behavioral contracts, which Dr. Blood will go over here in a few minutes. And then also with PCIT, would be special playtime. So this again is helping increase the positive moments between a parent and a child when there's no kind of arguments, no commands are being given. So this could be, it says 15-20 minutes on here. It could even just be something as small as 5 minutes where the child selects an activity that is interactive. So maybe not like video games or TV where their attention is elsewhere, like a board game or coloring, Legos or something like that for younger children where they can interact together. There's just lots of positive feedback from the parent, lots of approval to the child, not really asking questions or commands, and just filling them up with that positive attention. So that way they know, like, here's all the positive attention I can get, and whenever, outside of that time when commands are given, they're going to comply more to get that positive attention rather than negative attention. The special playtime shouldn't be removed for punishment. And for older kids, it could just be one-on-one time where they're doing something the adolescent really enjoys. So the other evidence-based treatment was the Barclay's Defiant Child Manual. It kind of goes over a lot of the same ideas and techniques for managing child behavior with the positive attention and ignoring, and then it also really goes into reward systems and token economies. So this is just another treatment that can be used in helping children with ADHD who are really struggling with their behavior. And then lastly, children with ADHD can often struggle with making decisions and in other aspects. And this is an acronym, the THINK acronym. I like to use it with my patients in lots of different aspects. So it just kind of goes over different questions to give the child a chance to think about what's going on. So for a kid who's really struggling with hyperactivity and impulse control, maybe they really want to just be running around the room crazy, and you stop them and just ask them, think through these steps. Think, is it true that this is what you want to do? Kid's gonna be like, yeah, of course. H, is it helpful for you to be running around the room when mom is trying to clean up? No. I, is it inspiring to anybody? No. And is it a necessary activity? No as well. And then kind, is it kind for you to be doing this while mom is trying to clean? No, probably not. And so if the child goes through and hits a no, it gives them a chance, think what else could be helpful in this moment. I like to use this acronym also, especially for children with anxiety or depression, and ask them, if they're really struggling with negative self-esteem thoughts, asking them to go through these questions to really challenge those thoughts and negative views of themselves or what's going on in their environment. So next, I'll let Dr. Blood take over the practical applications.
All right, everybody. Thanks, Mary. Let's see if I can get this going here. Here we go. Oh, went too far. So children who have ADHD are often do not seem to respond well as other children to social praise and attention. So while parental attention is very helpful at first in promoting more positive behaviors in children with ADHD, it is often necessary to use a more structured, high-powered, and salient rewards in addition to parental attention and praise. Well, I'm not having a very good luck controlling this. There we go. Now I can see where I'm at. There we go. All right, sorry about that. So some rules to follow when we're talking about positive reinforcement. Reinforcement follows a behavior and is contingent on the occurrence of that behavior. So the behavior must occur before the reinforcer. Now we're all familiar with Pavlov's, famous study with making the dog salivate. That was classical conditioning, which is not what we're going for. That's we're going for more operant conditioning, or operant conditioning. All right. And so number 2 part is the consequence is only a reinforcer that increases the occurrence of the behavior. And so if the behavior isn't changing, the consequence isn't serving as a reinforcer. Positive reinforcers can be social, such as praise, material, such as money, trinkets, like trading cards, or it can be an activity, like going out for ice cream, going to the mall, swimming, stuff like that. To be most effective, reinforcement should occur immediately after behavior. And you also have to explicitly define the target behavior and the reinforcers and provide prompts for when the behaviors are critical to success when working with a child with ADHD. So first you establish the new behavior, and reinforcement must be given each and every time desired behavior occurs. And then only after behavior is occurring regularly, then you can move it to more intermittent reinforcement. And that will strengthen future performance and behaviors. And so use activities as reinforcers as well. So like Sally, if you clean your room, then you can go to a friend's house. There's the grandma laws. If you do this, if you want what you want to do, then you have to do what I want you to do, and not the other way around. And so follow through is the most critical thing with behavioral plans. They have to be followed every day, all the time, or else the kids won't know. You're not going to be able to do this behavioral management. So advantages of a consistency management system is using tokens or points. They can be used immediately or they can be saved. Tokens and points provide an immediate step between the positive behavior and the eventual reward. And then tokens can be traded for many different rewards so the child maintains interest and motivation in the program. So how do you set up a home point system? So you can use a chart, and you put this chart in a very obvious place in the home, and so that it can be used and seen throughout the day. You have to sit down and explain that, and the best way to do this is put a positive spin on it. Say, hey, we're not rewarding you for doing enough nice things around the home, and we want to change that. And so we're setting up this reward program that you can earn privileges for when you're doing those positive behaviors that we want them to do. So you discuss the list of possible privileges. You list, you also have to kind of list special privileges. And then the second thing is you talk about the target behaviors, what you want your child to be doing. These, it can include chores, their normal self-care things, whatever you want to see them do. And so the points, they need to be, it's been recommended that you use multiples of 100. It's harder for them to stay engaged if the points are really low. So that's why you don't want to use 1 to 5. It should be like 100 to 500 points per item. And then you need to, these will add up, and you can you'll got to sit down and you'll see about how much they will earn in a day, so you can find out what's a reasonable thing for them. This is an example of a point sheet that kind of shows all the different behaviors and privileges. So this one, it shows on the top is their earning, and then the bottom is their spending, basically. Here's an example of a token economy. Tokens are basically like a poker chip where each token has a value assigned to it. But it's the concept is exactly the same. So here's some examples of rewards or privileges. So, you know, they have kind of routine things, snacks, dessert, playing a video game for such amount of time, watching TV for such amount of time. So those are all, and then those are all the common things that they would do. And then you kind of have above and beyond so that they can like save up their points to get these bigger privileges. And so a goal system is just kind of a slight variation of the point system. And because children with ADHD, they do better with single goals or a short list of goals. You can use goals instead of a lot of different target behaviors, so that you can get them focused a little bit better. And you have to do these in frequent intervals. And we'll talk about that here in a minute. And they have to be able to achieve these goals at least 75% of the time. Because if they're not going to be able to meet these goals, they're not going to have that buy-in. And so once the goals are accomplished or completed, then you check them off. And this can be daily or even hourly goals. And then once the goals are completed for that desired time frame, then the reinforcer is given. So if it's a daily goal, then the reward will be given tomorrow if it's for a certain time. Like if you're going to do a morning time, then they'll get the reward in the afternoon. And then the afternoon time, they get rewarded the following morning, which that's more likely to happen during the summer when they're not at school all day. So some of these can be changed around to fit whatever the schedule is. And the big thing to remember is that once a reward is earned, it can't be taken away unless for severe behaviors. So once they earn that reward, they get it, whether they aren't following those rules at the moment, because they did follow the rules earlier. Here's an example of one I found for a school, for elementary. And they're just checking off these boxes. You finish your homework, they waited in turn, you know, they stayed in their seat. Here's one for a smaller child where it's a sticker chart, where, you know, the stickers are really enforcing to smaller children. So the big thing is the 100-foot picture is reward the good and ignore the bad. That's kind of the whole gist of behavior management. So how do we maximize this? We start with behaviors that are relatively easy to accomplish in order to increase the likelihood of success. And you need to set specific times and deadlines so that they can complete these. And then you give them prompts. You can't continually giving them prompts. You have to set a maximum number of prompts, either 1 or 2 typically. The example here is be out of your bed by 7 a.m. with no more than 2 reminders. And then you always have to, the parent always has to maintain a positive attitude, smiling, pleasant tone, and the praise that Mary talked about earlier. And then you have to kind of give these rewards, or if you're using points or the tokens, you have to give them immediately. So as soon as they do that behavior, you have to give them that immediate reward. And that's only in the beginning, because then later you will switch to the intermittent rewarding. And it's often a good idea to define when they can redeem their tokens and privileges. There we go. So you always reward them for their good behaviors, and just kind of keep it as simple as possible. A good thing to remember is if the child is in 2 different households, so their mom's Monday through Thursday and dad's Thursday through the weekend, they both have to keep the same system going, or it won't be as effective. You have to kind of keep the rewards to what the kid want, because they will get bored easily with some of the smaller daily rewards. It's easier now that we have a lot of electronics, because the kids can kind of just pick whatever they want to do on the electronics, and that kind of keeps them from getting as bored if the reward is 30 minutes of electronics. And if they're not wanting anything that is on the reward list, you either need to change the reward list, or that means that they have too many already freely given activities that they're not needing rewards. So you'll have to cut back on what they are freely given. If they're already given a free amount of TV time, then they may not be willing. They may be willing to go without playing at a friend's house or going swimming, things like that. Here's some trouble. This is something I found online. It's kind of like a troubleshooting guide to things, contingency management system. So if just kind of follow the graph. It's pretty easy to do. So I'm not going to go through all of those. So I did want to kind of just put up a case example. Say a parent brings you an 8-year-old with behavioral problems. He doesn't follow directions. He doesn't complete tasks. He argues. He yells. He struggles at home and at school. Additionally, at school, he struggles with his grades, staying on task, fidgets often. He's had several incidents of fighting with others, talking back to teachers, or yelling at teachers and staff when attempts were made to intervene. School referred to outside therapy, but they're on a wait list. So what can a doctor do? So you screen for ADHD. First, you want to see if they actually qualify for treatment for ADHD. If they're younger than 5, the American Board of Pediatrics recommends that behavioral management first. If they're older than that, then studies suggest that medication management and therapy is the best combination. And so the therapy combinations, which Mary kind of went over, were CBT, behavioral therapy, and parent-child interaction therapy. But the parent's needing help now, so you can bring up these point or token or goal systems. So here's kind of a basic daily goal chart that I made for an 8-year-old. 8-year-old, it's kind of there on the cusp if you want to do daily or half day. And then you may even want to throw in some hourly things, but this was just kind of a very generic. You want 8-year-old behavior, and so that's kind of defined by the parent and the child. What is a typical 8-year-old responsible for doing? They shouldn't be yelling. They shouldn't be crying all the time. They shouldn't be hitting, things like that. That's kind of standard 8-year-old behavior. They should be able to wait patiently. And so some of these kids will need behavior modification plus medications to be able to accomplish that. So that's as your PCPs. That's your that's kind of the 2 components that you'll be managing there is. And I put on here complete tasks with only 1 reminder. It can be 2, sometimes 3, depending on where the starting point is for the child. So that's kind of just a basic one I put together just to kind of show what a goal chart could look like for this 8-year-old. I did want to share some common handouts that are free and online. These 2 are from the CDC. The CDC has very good handouts for just about anything out there. So these are some of the ones that I found from the CDC. There's also one specifically for primary care doctors to kind of how to talk through these things with a parent and kind of show them what they're looking for in a therapist. I just couldn't fit all these on one slide. Another good place to get handouts is from CHADD, and it's Children and Adolescents with ADHD. And these are longer. I think the one on the left is a 4-page handout, and the one on the right, I believe, is only 2, maybe 3 pages. And these are a lot more detailed than the CDC's, so they'll go into a lot more about the specifics of each of these things. Here's some good websites. I already mentioned 2 of them, the CDC and CHADD. And then there's several of them out there. These are just 2 that I've found. The Child Mind Institute has a lot of good stuff on there. And then the ADD and ADHD solutions. But like I said, there are so many out there. But I would start with CDC and CHADD. These are our references. And that is the end of our presentation.
Thank you, Dr. Baker and Dr. Blood. We appreciate the presentation today on the behavioral management of ADHD. We do have a couple questions, and if others have questions, we ask that you please add them to the chat. We're going to go ahead and touch on those now. The first question we had was specifically about the charts, and that was early on, Dr. Blood, within your part of the presentation. My question, let me go back. Dr. Beckerly, can you tell me more about, I'm not sure if it's Dr. Beckerly. Yes, which chart you're wanting? Are you able to unmute yourself?
And I'll try to answer this more broadly. There's a lot of different charts out there. You know, a lot of these can be found online for free. A lot of times it's just kind of working. You kind of have to modify them to the child's need. And so once the parents kind of know what they're looking for and you've kind of explained how these systems work, they should be able to modify what they find online. There's so many out there.
All righty. And Dr. Beckerly did say that she saw some charts that you had provided, so I think we're good there. Now, another question came in, screen time question. What is the recommended amount of screen time at this point? And I'm going to throw in, does it differ from age group?
You know, I don't know the most current. I believe the American Academy of Pediatrics puts one out, and I believe the Academy of Child and Adolescent Psychiatry puts one out. And I don't remember them off the top of my head, so I can't really. Maybe if one of the other providers on here know, I just don't remember that off the top of my head. But it's less, I would say, would, you know, the better. You know, they do need social interaction.
One of our
but
attendees,
it just kind of have to adjust it to the child.
Okay, one of the attendees mentioned that screen time was no more than 2 hours a day, and that's from one of our pediatric nurse practitioners. So where they can verify that is through the American Academy of Pediatrics, what their recommendations are. Is that correct, Dr. Blood?
They have had recommendations. They have put out recommendations for that.
Okay, super. Any other questions? If you would please place those in the chart, the chat, that'd be great. And Dr. Kerr said, yes, AAP recommends under 2 hours a day for adolescents and under age 2 to no screen time at all. Thank you, Dr. Kerr. Dr. Kerr is one of our other child psychiatrists here on our team, one of our 3. Any other questions? I'm going to just leave for just a second here, leave the chat open, and see if there are any other questions from attendees. I will ask one question, and this is for either Dr. Baker or Dr. Blood. What do you find as the biggest challenge for a provider when working with the family unit who has a child with ADHD?
The biggest challenge, you know, is finding the right combination of things that work. There's no one size fits all. And so you do have to, you know, finding the right type of medication that's going to work well with the least amount of side effects, and then whichever, you know, parenting skill that works well for that family and in that setting. So, like I said, there's no good one size fits all. I don't know if Dr. Baker has any thoughts on that.
Yeah, I would definitely agree. I would say based on the therapy side of it, a lot of it can be um, like difficulty with consistency with parents, whether it's, their time is just so constricted or the child is in so many places that it can be hard to have the parent really consistent. So just like really stressing that these are techniques that have been researched and shown that work, like especially with the reward charts and positive attention. So really stressing that to parents has been probably one of the hardest things I've seen.
Thank you, Dr. Baker. Another question's come up. Is there a relationship between the type of cartoons kids watch and ADHD? Any thoughts on that from either of you?
I would say there probably is, but I don't remember off the top of my head reading any specific articles that talk about that. It seems more anecdotal that children with ADHD like the more fast-paced, moving storylines, a lot of scene switches, just because that helps them sustain their attention with one thing. That's why movies are so hard for kids with ADHD. There's not enough scene changes for them. But I don't know if one's going to exacerbate symptoms or not, if that's kind of what you're getting at.
Thanks, Dr. Blood. I don't know if you have anything to add to that, Dr. Baker, or not.
Yeah, I think the only thing I would add is like not specifically to ADHD, but if the child has a lot of behavioral problems associated with that, I've seen some research that shows like more violent cartoons can lead to those behaviors more often. But I mean, that can be with any type of mental health diagnosis.
All right, thank you. Any other questions? All right, so what I'm going to do is move on to providing just a bit more information. First of all, I'm going to talk just briefly about CPAN, the Child Psychiatry Access Network. I'm going to take the screen here real quick. So for those of you who are providers here today, if you are not familiar with or already enrolled in the Child Psychiatry Access Network through the state of Texas, we'd like to be able to share more information with you about that. CPAN is available through funding through the state of Texas. It is available for all 254 counties in Texas. And there are 12 hubs, we are one of those, that serve different regions throughout the state. The hub here today through UT Health Science Center in Tyler serves the 25 Northeast Texas counties. We currently have over 110 clinics enrolled and more than 430 PCPs across our region, and that is growing daily. Services provided by CPAN are at no cost because of that grant funding, and we provide real-time child and adolescent psychiatry consultation, non-pharmacological intervention consultation from our psychiatrists as well as our therapists, Wiley and Elizabeth, that are on our team. And then we also can assist in identifying validated referrals and resources for mental health services for continued support. All of this is for children and adolescents through age 18. And all you have to do is contact us at the number below, 888-901-2726. We ask that you press option 1 and then option 3, and that'll get you directly to our team. We are a Northeast Texas university serving Northeast Texas providers. So for more information, you can contact us at the email address above, the cpaninfo@uthct.edu, or give us a call. We're here from 8 to 5, Monday through Friday, excluding institutional holidays. The next thing I want to share with you is we have something new and exciting coming to CPAN. And let me get this up on the screen as well. We have Project Echo that will be starting in August of 2020. If there are any individuals on the call today who are not familiar with Project Echo was developed through the University of New Mexico and is a service where experts in a field, it can be any field, come together with small cohorts. Our cohorts will be less than 30 to learn about specific topics in that field of itself. We will, as Texas CPN Hubs, be facilitating 7 sessions across a wide array of child and adolescent mental health topics, which you can see at the bottom left. We would love to have PCPs from across our region join us for these sessions. They will be held on Fridays from 12 to 1 p.m. For more information or to register for our fall session, we ask that you complete this interest form below. You can either do that through our QR code, which I will leave on the screen for a bit longer, or you can contact our direct form at this form address below. I'm sorry, you'll have to screenshot that. It's not obviously a live link for you. But we would, again, love to be able to provide this additional education to you. This service is limited to 30 PCPs for our sessions here. And our psychiatrists, our 3 psychiatrists, as well as our behavioral health specialists and myself, we will be on those calls. They are through video. They will be held through Zoom. And we'd be excited to share our expertise and information with you, as well as help you get to know our providers a little more, more in depth. The last today I'm going to provide for you is your QR code so you can get your CMEs. One moment, please. And here you go. So we thank you again for joining us for our topic of this this week, behavioral interventions for ADHD. You can contact us for your QR code above, with the QR code above, and then I will also put that code in our chat. Oftentimes, it's already been put in there. Let me see if I can get that code for you. Nope, I'm not able to. There is.
I got it, Laura. I got it. I already put it in the chat for you.
Thank you. I don't have access to the chat when I have the screen up. I appreciate it.
You're welcome.
So either through the QR code or through the form. Again, we thank you so much for joining us today. Again, we hold continuing education offerings every first and third Wednesday of the month. Our next session will be Clinical Pearls for Primary Care, treating children and adolescents for ADHD. This is a reprise of one that was done earlier this year. We've been asked to present it again for those who weren't able to attend previously. We hope that you can make our CME offerings in the future and are excited to be providing you with an ECHO project beginning in August of 2020. Any questions email us cpaninfo@uthct.edu. And we appreciate you joining us today. Thank you.